I sent 4 topics, and maybe somebody like to talk something about hypertension or about antiphospholipid syndrome, because are all topics that we are specialized in that. But of course, it's not enough time just to talk about all of that points. But if there is some question from the audience about that, and also another topic that was proposed from the university was RH disease and the treatment in RH disease. Also, I can just have some question from the audience, answer a question from the audience about that. Have any question?
I do have a question. The SCU that you described, the special care unit, who staffs it? I mean, is it only obstetricians, or do you have any other physicians and staff?
Yeah, the staff, the general staff, is just obstetrician. Obstetrician specialized in high-risk pregnancy. That means the consultants. The consultants are coming there, of course, with the doctors in training and with the students, but they are in charge for the consultants, this part. But they receive the visit for the other specialties, because it's a general hospital. That means there's some lady who have kidney problems and need dialysis many times. Okay, the nephrologists are coming and checking the ladies. Cardiologists are coming, toxicologists are coming the other specialties, and we have rounds with all the specialties, and they interchange ideas on how to manage that ladies.
In other words, it's not like in a typical intensive care unit where you have a full-time attending staff who's there the whole day.
Yes, you have staff the whole day, because this unit is close to the labor place we call the perinatal department. The perinatal department is the place where there are 4 TPR, pregnancy, labor, delivery suites, 4 of them, and also 2 operator rooms. And this is exactly on the side of that. That means that the doctors on call that are in that part are also in care these ladies. Those are the ladies who are care the whole day. Apart from that is the work with the general population, the puerperium and the lady who maybe has another problem, but the maternal fetal medicine problem, another problem who don't need to be cared 24 hours.
The overall rate of complications in the unit is higher in cesarean versus vaginal delivery. So what's your rate of cesarean in your hospital?
Oh, it's high. The rate of cesarean section is at the hospital is 36%, 36% now. First, because we have high-risk pregnancy, many ladies who has hypertension and very severe hypertensive disease or her symptom that they need to go to C-section because of intrauterine growth retardation and fetal demise many times, and also because previous C-section with acretics, because also lady for another hospital who has not hemodynamics 24 hours to make a catheterism just to treat the lady with acretics, they are coming to our hospital, to our department. That means that there are many surgical problems coming in the department.
I understand that for some private hospitals in Buenos Aires, the rate is much higher than that. So your rate is relatively low, right?
Sorry?
The rate in some private hospitals in Buenos Aires is
yes, it's
higher.
very high. Yeah. Private hospital in Buenos Aires has approximately 60% of cesarean deliveries. But you know what had happened? Private hospital means just one doctor with one patient. That means that it's one doctor in charge of this patient all the time. And there are many litigations. And the doctors, before to have any litigation, they prefer to make the C-section many times. That means if there is an intrauterine growth retardation, not too important, but at least they make the C-section. If it is a hypertensive disease, they make all the time the C-section. that means that the rate for C-section in private hospital is high. But especially because of legal problems. Because the judge always said, why you don't perform a C-section 5 minutes before? And because of that, all go into C-section. They said, I made a C-section, and then that's a problem. It's a big problem, litigation. We have litigation after United States, because the litigation starts here, and then they copy there. Sorry?
Do you have midwife service in one service?
Yes, midwife service, but midwives are working with us in the hospitals and also in the clinics. Okay, we have many schools of midwife, and also I have midwife students in my department. And midwife residency. There is a midwife residence system in Buenos
They
Aires.
do the normal deliveries on the unit?
Yeah, they have the possibility to make the normal deliveries, of course. At the hospital, the staff midwife, of course, it is very difficult for them to make, for the midwife to make the normal deliveries, because you have residential program, a midwife residential program, students, and they like to make the normal deliveries. But they have the ability to make the normal deliveries, whatever. Not the high-risk pregnancy, of course. They must make by doctors. But for the pregnant ladies, still in Argentina, the pregnant ladies feel that the doctor must care must be in charge of the delivery. That is the general view for delivery. But the midwife has an important role because they are all the time during labor. There's a person who stayed before during the prenatal education and special prenatal courses, and they explain about labor, delivery, how to care the baby, about the breastfeeding. All are in charge of the midwife. Have an intensive activity in my country.
Well, here, there was a move to build ICUs right next to labor and deliveries, basically in the 90s. But it kind of fell apart. I think they were just hard to maintain the expertise because they were much more sophisticated. They did have respirators and everything else connected to it. And eventually they basically kind of gave up. There's a few places like Sabine, places like that where they've got tons of fellows around to run a unit, they would keep it going. But here, what we're doing more or less instead of that special care unit is basically doing the same thing in the recovery room or in our LDR to keep fairly sick patients there. And then the issue becomes, when the patient gets a little bit too sick, how do you make the move from your recovery room up to the ICU at the right time? And so it's been interesting. Our department has had quite a history of getting those decisions to happen easily at the right time. And now, happily, it actually works very well. We'll just call in an ICU consult. They'll come down and evaluate the patient. And then now, relatively easily, sometimes even before we expect it, they'll actually move them up into the ICU. In our system, the ICUs are just jammed full of very old patients who are taking beds. And of course, we are very biased here, and we want our patients to kick the other ones out.
Yeah. Yes, this is one of the problems, no? Just to put the pregnant lady at the intensive care unit, the general intensive care unit, it's just to put the lady in the surroundings that is not so good for pregnant lady, because that lady are still pregnant. That's the other point, because you have a lady who have drepanocytic anemia with TOP. Of course, they must stay in the intensive care unit. But I remember for that lady that for us we have not experience about drepanocytic anemia, that very difficult case, the Angola patient who decided just to come to our hospital. I'm very lucky our hospital to receive that lady. I had TAP many times, and the intensivists, we are in touch all the time, and they say, why you don't finish the pregnancy? I said, finish the pregnancy because the lady is coming to die, finish the pregnancy. And we support the pregnancy on the other side. And it was a very difficult decision that to take all the teams together. But in another cases, for example, ladies who have some cardiac disease, but they are completely communicating with everybody. I put this lady into the intensive care unit. Then I see all the time the other people who are coming to die because they are very old people, or people who are coming to accidents. And this is not a very good environment for pregnant ladies. That was the decision for me to build this special care unit. And I did that 12 years ago. But it doesn't exist in other places, intensive care, this special care unit. And now this, most places are talking about a special care unit. Because I think that you need to put a hypertensive lady in one place, the very severe preeclampsia. We got very severe preeclamptic ladies, health syndromes that we are taking care there. And if you see the ladies who are coming to intensive care unit, there were very few. That was the lady who cannot be managed in our special care unit and were transferred to intensive care unit because they need another things. But the rest of the ladies are still there. Antiphospholipid syndrome, the terrible antiphospholipid storm syndrome, autoimmune disease. Many of those ladies we got in our department, and all of them are taken care in the special care unit. And it's good to also for training. It's also for training for students and for residents, of course, because they just have all the ladies together, and the other doctor for the other specialties are coming and make a very nice rounds all together. I think it's a very good experience for us to have this system.
Do you let the babies visit on the special care unit? If the baby's delivered, are you allowing breastfeeding and contact with their babies?
Yes. Yes.
Restricting them there?
No. They can go to stay with the mother there. It's done in the special care places. Okay. In the first 24 hours, of course, after C-section, after that, no. But after that, when the patient is recovery for the delivery and we can manage the disease and we can stay in the special care unit, the baby is with the mother all the time, yeah. In any place in our hospital, the baby is with the mother. We have something, I don't know it here, the UNICEF create this hospital friends for mother and child. I don't know if it's here that exists in United States. UNICEF create 10 conditions to qualify hospitals like friend of mother and child.
Baby friendly.
Baby friendly.
Baby friendly here.
Yes, it's baby friendly here. Yes, hospital that everybody at the hospital know. As there could be pregnant ladies coming and babies. It is very difficult to qualify. I must say that my hospital doesn't, because it's a high-risk hospital. And when somebody from the transplant cardiac department, you ask, do you know about the pregnant ladies? They say, what? Pregnant lady? What is that? It's very difficult to qualify because anybody at the hospital must know what happened in our flat. And that is very difficult. That is very difficult. I don't know here if that happened. You know that people say that the most important thing is to be the nurses for cardiac transplant department and not the nurses for pregnant ladies. I don't notice that special way of thinking happened here in this country. But in Argentina it's very common. It's very common to say the most important just to be at the kidney department or the thoracic surgery department, but not in the OBGYN department. It's not very good qualified for the rest of the people.
Any other questions? Great, thank you so much.
Okay. Thank you very much.
Only this section.
There are in this, it's a handful of fellowships, high risk pregnancy.